Today, we're taking a really detailed plunge into what is probably the most complex and sensitive structure in the entire human body, the central nervous system. Our source material is a massive stack of comprehensive pathology notes. We're talking textbook sections, detailed gross anatomy diagrams, and of course, some beautiful high-resolution microscopic H&E slides.
It is an immense mission.
It is. This isn't just theory. It's a rigorous visual tour of brain affliction.
And it's one of critical importance. We are, in a way, bypassing months of clinical training to zero in on the exact cellular and architectural signatures of disease. What makes the CNS so unique is its limited capacity for regeneration.
Oh, yeah.
Unlike other organs, every injury leaves a distinct and often permanent pathological fingerprint. We really want to help you master this complex visual language.
That's the core mission. We are translating these dense, intricate images, this subtle red tinge of a dying neuron, the characteristic honeycomb pattern of a brain tumor, the cystic cavity left by an old stroke into understandable insights. We're covering everything from how cells react to injury, the crisis of pressure within the skull, the consequences of trauma, vascular failure,
Infections and the relentless march of degenerative diseases and tumors, it's a lot.
It is a lot. So we've structured this journey into 7 conceptual zones, just to keep it clear.
And our commitment is to explore the pathology of CNS injury, from the macroscopic changes you might see on an MRI or, during a gross autopsy like a massive hemorrhage, right down to the microscopic reality of protein aggregation and cellular destruction you see under the microscope.
Exactly. We want you to connect the vast structural damage with those tiny specific details that make the final diagnosis. Okay, let's get into it. We have to begin with the basics because the rules of injury change entirely once you enter the brain. Why does CNS injury look so fundamentally different from, say, a cut on your arm?
It boils down to specialization and a very limited repair capability. The key actors, the neurons, are metabolically hyperactive.
I've heard they consume something like 20% of the body's oxygen.
That's right. And yet, they are almost entirely postmitotic. If a neuron dies, it is not simply replaced by another neuron. This specialization mandates entirely unique patterns of reaction and, destruction.
So let's talk about those critical neuronal reactions. We should probably start with the concept that determines where the damage hits hardest: selective vulnerability.
Yeah, that's a great place to start. Neurons are not interchangeable. While general stressors like, say, hypoglycemia or trauma can hurt everything, specific populations are exceptionally susceptible to a global injury.
For instance,
the pyramidal neurons in the hippocampus, which are absolutely critical for memory, and the Purkinje cells of the cerebellum, critical for coordination. These are notoriously sensitive to even transient global ischemia.
like what might happen after a cardiac arrest?
Exactly. Understanding this vulnerability explains why a patient who survives a major shock can still have profound and permanent neurological deficits in specific areas.
Okay, and when a neuron does succumb to an acute injury, there's one classic, definitive microscopic sign that tells us precisely what happened.
That is the unmistakable red neuron morphology.
The red neuron.
If we are looking at tissue that experienced acute, irreversible hypoxic or ischemic injury, lack of oxygen or blood flow, the neuron undergoes a specific series of changes. The cell body shrinks dramatically, its nucleus shrivels into a dense, dark mass we call pinosis, and the cell loses its normal internal structure.
And the red part.
Crucially, it loses its basophilic or blue-staining Nissl substance. That's the rough endoplasmic reticulum. The loss of that blue staining causes the entire cytoplasm to become intensely eosinophilic, or red, in an H&E stain.
So why is the timing of this red neuron so important for the pathologist or the clinician looking at post-mortem tissue?
Because it's not instantaneous. That's a key point. The cellular machinery has to struggle and die for hours before this morphology is visible.
So if you're examining a brain shortly after death.
Exactly. Even if the person suffered a lethal injury, the red neuron might not have developed yet. We usually require a survival window of 6 to 12 hours after the insult to reliably identify this definitive sign of acute ischemic death.
That's fascinating. Shifting gears from acute death, let's consider what happens if the injury is focused on the long cable, the axon, rather than the cell body. I understand there were 2 very different reactions.
Yes, and we have to distinguish between the reaction distal to the cut and the reaction happening back at the cell body. The first is Wallerian degeneration. If you sever an axon, the entire segment distal to that injury rapidly degenerates and breaks down.
So everything after the cut just dies off.
It does. And this process involves the clearing of that debris by surrounding glial cells and macrophages. It is the hallmark of traumatic transection.
Okay, and what happens back at the main processing unit, the cell body itself, in response to that lost connection?
That's the axonal reaction, or chromatolysis. And it's a remarkable attempt at repair. The cell body swells up, the nucleus often gets pushed to the periphery, and the Nissl substance, that critical protein manufacturing machinery, disperses from the center out to the edges.
So the cell is basically gearing up for a big construction project.
It's essentially shouting, I have lost a major connection. I need to start synthesizing new materials immediately to try and regenerate that axon. It's a pathological sign of regenerative intent, even if that regeneration rarely succeeds in the CNS.
Here's where it gets really interesting for me. The support crew, the neuralia, they jump in immediately. In the rest of the body, injuries are handled by fibroblasts and peripheral immune cells, but in the brain.
In the brain, it's the glia that take over. They are the critical second line.
So let's start with the astrocytes.
The astrocytes are the structural and regulatory cells. They maintain the blood-brain barrier integrity, they regulate neurotransmitter levels, and in pathology, they become the primary repair mechanism. Their universal reaction to injury is gliosis.
Okay, can you describe gliosis conceptually for the listener? What is it?
Gliosis is the CNS equivalent of scarring. But instead of collagen, it's built from these highly specialized cells. It involves both the enlargement or hypertrophy and the multiplication hyperplasia of the astrocytes.
And microscopically, what's the telltale sign? How do we know we're looking at gliosis?
The key is a massive upregulation of GFA, glial fibrillary acidic protein.
So when we see a slide showing intense GFAP staining, what are we actually looking at?
You're seeing the scaffolding. The intermediate filament skeleton of the astrocyte is just lighting up brightly. It confirms that the cell is stressed, enlarged, and actively building a dense, fibrous meshwork. The source material shows how these reactive cells look. They are fibrous, large, and spreading their extensions into the injury site, effectively walling it off.
And we also have two specific, unique morphologies for astrocytes that point to very different underlying causes.
That's a crucial distinction for diagnosis. First, you have the generalized reactive ones, the gemistocytic astrocytes, associated with acute injury. They're plump and eosinophilic. But the real pathology trap, the one you have to know, is the Alzheimer type 2 astrocytes.
That name is a classic misnomer, isn't it?
It is entirely misleading, and you should file this away as a core nugget. These cells, which have these strikingly large, pale, and balloon nuclei with almost no visible cytoplasm, are not associated with Alzheimer's disease at all.
So what are they associated with?
They are pathognomonic for severe hyperammonemia. This typically occurs in patients suffering from end-stage liver failure or hepatic encephalopathy. It's the brain reacting to toxic levels of ammonia, a systemic metabolic crisis, not a primary degenerative disease.
Fascinating. Now, for the brain's resident immune sentinels, the microglia, what is their job and what happens when they switch into active mode?
Microglia are the CNS version of macrophages, derived from the yolk sac. They are constantly conducting immune surveillance. When activated by disease, neurodegeneration, or infection, they morph from their resting, ramified state into active, phagocytic cells capable of devouring cellular debris, pathogens, and misfolded proteins.
And what are the two key ways we see activated microglia clustering?
When injury or neuronal death is diffuse, they cluster together, forming microglial nodules. These are small, visible aggregates of activated immune cells trying to clean up the mess. Alternatively, in certain chronic infections, particularly neurosyphilis, they adopt a very long, thin morphology known as rod cells. Seeing either of these is a definitive sign of ongoing inflammation or chronic infection within the parenchyma.
And we can't forget the cells responsible for insulation and plumbing, oligodendrolia and ependymal cells.
Right. The oligodendrolia create the myelin sheath in the CNS. Their injury directly causes demyelination, which is a major focus later in our dive. Diseases like the leukodystrophies or the viral infection PML specifically target these cells, stripping that protective insulation from the axons.
And the ependymal cells.
The ependymal cells line the fluid-filled ventricles. Inflammation or viral infection can damage them, leading to granular ependymitis, where you see these small reactive nodules forming on the ventricular lining.
Okay, the moment we put a soft, delicate organ into a rigid, unyielding container, the skull, we create a zero-sum game for space. Any swelling becomes a crisis of escalating pressure that can rapidly lead to irreversible damage.
That's why managing intracranial pressure is the most immediate life-saving maneuver in neurotrauma. And the foundation of this crisis is cerebral edema.
The accumulation of fluid.
Yes, which we categorize based on where the fluid goes and why.
How do we clearly differentiate the two main types, vasogenic versus cytotoxic?
They reflect two distinct failures. Vasogenic edema is the most common. The cause here is a failure of the physical barrier. The blood-brain barrier breaks down.
Often due to a tumor or inflammation.
Exactly, or severe trauma. This allows plasma proteins and fluid to leak from the vessels into the extracellular space. It primarily accumulates in the white matter, making it look swollen and pale. In contrast, cytotoxic edema is an internal failure. This occurs when the cell itself is damaged, say, by severe ischemia. The cellular energy pumps fail, which leads to an inability to maintain ion gradients.
So water just rushes in.
Water floods into the cells. Neurons, glia, endothelial cells, they all swell up, trapping the fluid intracellularly.
And this type is often more generalized.
Yes, and it affects both gray and white matter equally. Critically, you often find both types coexisting, which just multiplies the risk.
That generalized swelling that impairs the drainage system, which leads us directly to hydrocephalus, the plumbing problem of the brain.
Hydrocephalus is simply the excess volume of cerebrospinal fluid, or CSF, within the ventricular system. Our sources show this visually. You see these coronal sections with dramatically dilated lateral ventricles.
We know CSF is produced in the choroid plexus. What are the three mechanical issues that can cause hydrocephalus?
The problem is usually flow or absorption. So the three mechanisms are: 1, overproduction, which is extremely rare, usually from a tumor in the choroid plexus; 2, obstruction of flow, which is the most common mechanism, where the fluid can't move through narrow passages like the cerebral aqueduct; or 3, impaired reabsorption, usually due to scarring or blockage in the subarachnoid space where CSF should drain into the venous sinuses.
And we also talk about communicating versus non-communicating hydrocephalus.
Right. We divide it into obstructive, non-communicating, where flow is blocked within the ventricular system itself, or communicating, where the flow between ventricles is open but absorption downstream is blocked.
So what does this all mean when the pressure continues to rise? The brain has nowhere to go, forcing it to shift. This is herniation, the most catastrophic mechanical shift.
Herniation is life-threatening because it causes secondary compression and vascular damage. Our sources highlight 3 critical syndromes you must understand visually and conceptually.
Let's walk through them.
First, the subtle shift, subvalcine or cingulate herniation. Here, the innermost part of the frontal lobe slides underneath the falx cerebri.
And the primary risk there isn't the shift itself, but what gets compressed.
Precisely. The primary risk is compression of the anterior cerebral artery, potentially leading to infarction of that artery's territory.
Second, and the one that signals a rapid decline, transtentorial herniation.
Also known as uncal or mesial temporal herniation. This is when the medial temporal lobe, the untus, is forced downward through the tentorial notch, which is a relatively small opening in the dura. The immediate effects are diagnostic and devastating.
What are the 2 key structures compressed here that give us those classic clinical signs?
First, the third cranial nerve, CN third, which lies right next to the herniating temporal lobe. Compression results in a key clinical sign: ipsilateral or same-side pupil dilation.
Okay.
Second, the posterior cerebral artery is squeezed against the tentorium, which can lead to infarction of the occipital lobe and visual loss.
But the most lethal secondary consequence is the distortion of the brainstem, which we see pathologically as Durette hemorrhage.
Yes. That lateral and downward movement of the brain stretches and tears the small penetrating arteries that supply the delicate midbrain and pons. This results in these linear or flame-shaped hemorrhages within the brainstem itself. Seeing a Durette hemorrhage is a definitive sign of severe terminal herniation, often preceding cardiorespiratory collapse.
Finally, the terminal shift, where the brain is forced into the spinal canal.
Tonsillar herniation. This is the displacement of the cerebellar tonsils down through the foramen magnum.
And while the shift itself might be small, its location is critical.
It's absolutely critical. It crushes the vital respiratory and cardiac regulatory centers located in the medulla, leading almost immediately to cardiorespiratory arrest and death.
Moving from the internal pressure crisis to external mechanical trauma. We'll start with the direct bruising of the brain tissue, or contusions.
Contusions are the bruises of the brain. And the defining pattern here, especially in forensic and trauma pathology, is coup and contra coup injury.
Can you explain that mechanism? Because it helps us understand how you get a dual injury from a single blow.
The coup injury occurs directly beneath the point of impact, but the brain, which is suspended in CSF, accelerates and then slams into the inner surface of the skull on the opposite side.
Causing the contra-coup injury.
Right. And importantly, these injuries are not diffuse. The damage occurs where the crests of the gyri strike the bony ridges of the skull base, most often in the frontal and temporal poles.
And what do these look like over time?
Acute contusions are grossly visible as these wedge-shaped areas of hemorrhage and tissue destruction. As they heal, the necrotic tissue is removed. What remains is a distinctive yellow-brown patch on the surface of the brain.
A residue of the trauma.
A residue. And that coloration is due to the cleanup crew. Hemosiderin-laden macrophages, the phagocytic cells full of iron pigment from the broken-down blood. We call this residual staining siderosis.
Okay, now we have to address the life-threatening accumulations of blood between the skull and the brain membranes, hematomas. We absolutely must nail the distinction between epidural and subdural.
This is a diagnostic cornerstone. Let's start with the rapidly dangerous one, epidural hematoma, or EDH.
Okay, so location.
Between the skull and the outermost layer, the dura.
Source.
Almost always arterial. It stems from the tearing of the middle meningeal artery, typically associated with the skull fracture overlying the temporal bone.
And the shape is key here.
The shape is key. Because the dura is tightly adhered to the skull, the high-pressure arterial bleed can't spread out. Instead, it forcefully strips the dura away, resulting in a characteristic, localized biconvex or lenticular lemon-shaped collection.
And this requires urgent surgical decompression.
Immediately.
In stark contrast, subdural hematoma, or SDH, is slower, but often stealthier and more common.
And SDH is blood collected in the potential space between the dura and the arachnoid.
And the source is different.
It's almost always venous. It results from the tearing of the fragile bridging veins that cross the subdural space to drain into the venous sinuses.
Which explains the shape.
Exactly. Since the blood is under lower pressure and the space is less restrictive, the hemorrhage spreads out easily over the cerebral convexity, adopting a distinctive crescent or sickle shape.
And you mentioned vulnerability. Why are infants and the elderly so susceptible to this?
It's a mechanical issue. In infants, it's due to excessive head movement causing tearing. In the elderly, cerebral atrophy causes the brain to shrink, which stretches those bridging veins taut, making them rupture with even minimal trauma.
And the SDH organization timeline is crucial for understanding the chronic presentation of these bleeds, isn't it?
It is. And SDH doesn't just resolve, it organizes. After about 1 to 3 weeks, the subacute phase, the clot begins to lyse. By the chronic phase, fibroblasts from the dura start to form a complete, organized, hyalinized capsule around the liquid blood.
And the danger is that it can rebleed.
That's the danger. The neovascularization in this fragile capsule makes it highly susceptible to rebleeding, leading to a chronic SDH that can cause fluctuating long-term neurological symptoms.
Now, the long-term implication of repeated subconcussive trauma has been a huge focus in recent years. Chronic traumatic encephalopathy, or CTE. What is the pathological proof of this condition?
CTE is the chronic sequela of repetitive mechanical injury, seen predominantly in athletes and military personnel. Pathologically, it's defined by a unique pattern of protein aggregation, specifically the accumulation of tau-containing neurofibrillary tangles and often TDP43 inclusions.
Okay, but Alzheimer's disease also involves tau tangles. So how does the pathology of CTE distinguish itself microscopically?
That is the key pathological nugget. In CTE, the tau accumulation is not diffuse throughout the cortex in the same way. The cluster specifically around small blood vessels and, critically, deep within the sulci of the folds of the brain.
And in specific locations.
Particularly in the frontal and temporal cortices. This unique perivascular and sulcal pattern strongly suggests that the mechanical shearing forces of trauma initiate the protein misfolding and aggregation. It creates a physical explanation for the disease mechanism.
We transition now from trauma to spontaneous failure, cerebrovascular disease, or stroke, which remains a massive public health concern. We'll divide this section into blockages, ischemia, and ruptures, hemorrhage.
Focusing first on focal ischemia and infarction. An infarct, or ischemic stroke, is tissue necrosis resulting from a lack of blood flow. The outcome is fundamentally determined by the vascular anatomy.
And we always talk about the circle of Willis. Why is collateral flow so vital here?
The circle of Willis is a safety valve. If a major vessel, like the internal carotid artery, is blocked, a complete and functional circle allows blood to reroute and potentially save the territory downstream.
But if the circle is anatomically incomplete,
which is common, then the infarct will be much larger and more devastating.
let's translate the highly specific temporal changes in a cerebral infarct. Pathology charts this evolution across days and months.
All right. In the acute phase, that's 0 to 48 hours, the visual evidence begins with the red neurons appearing after about 6 hours. The tissue swells due to cytotoxic edema. Within 24 to 48 hours, the initial inflammatory response begins, marked by the infiltration of neutrophils.
Okay, so that's the first response. Then what happens?
Then we hit the subacute phase, from 2 days to about 2 weeks. This phase is dominated by the cleanup crew. We see a massive recruitment of macrophages, and they transform into these distinctive phagocytic cells with foamy, lipid-rich cytoplasm as they engorge themselves on the necrotic myelin and cellular debris.
The foamy macrophages. That's the hallmark of a subacute infarct.
It is, and around the margin, astrocytes also start proliferating, laying the groundwork for the scar.
And what does a healed infarct look like months later?
The necrotic tissue is completely liquefied and removed, leaving behind a wide, fluid-filled space. We call it a cystic cavitation.
And that cyst is surrounded by...
It's surrounded by a dense, fibrous meshwork created by the hypertrophied astrocytes, the gliomas. The brain basically trades functional tissue for an empty, scar-walled space.
You mentioned shock infarcts earlier, the watershed infarcts. Where are they located and why?
These are the boundary zone lesions. They occur in the regions that receive the dual overlapping blood supply between the territories of the major arteries, the anterior, middle, and posterior cerebrals.
So the areas that are furthest from the source.
Precisely. When blood pressure drops globally, like during cardiac shock or major blood loss, these boundary zones are the first areas to suffer profound hypoperfusion. They appear as bilateral, wedge-shaped cortical areas of necrosis, directly reflecting that systemic circulatory collapse.
Now contrasting the large territory infarcts with the small, deep ones, the lacunar infarcts.
Lacunar infarcts are tiny lesions, only 3 to 15 millimeters in diameter. They're caused by the disease of tiny, deep, penetrating arteries.
And this is highly associated with hypertension.
Yes, specifically lipohyalinosis and arteriolosclerosis, which is almost always secondary to chronic, uncontrolled hypertension. They're typically found deep in the white matter, the basal ganglia, or the pons. And while many are silent, cumulative lacunar damage is a primary driver of vascular dementia.
Shifting to the second major category of CVD, intracranial hemorrhage, starting with bleeds inside the parenchyma itself.
The primary cause of acute spontaneous intraparenchymal hemorrhage is, overwhelmingly, hypertension. Just as chronic high pressure damages small arteries elsewhere, it causes fibrinoid necrosis and weakening of the deep perforating arteries in the brain. When they rupture, the resulting bleed is a massive compressive clot.
And the locations are highly predictable, right?
Extremely so. You should memorize these. The most common site is the basal ganglia, specifically the putamen, followed by the thalamus, the pons, and the cerebellum. Grossly, the acute hemorrhage is a dense, purple-red clot that physically displaces and destroys the surrounding functional brain tissue.
And while hypertension causes these deep bleeds, we have to recognize cerebral amyloid angiopathy, or CAA, as a separate cause of hemorrhage in the elderly.
Right. CAA involves the deposition of amyloid beta protein, the same protein involved in Alzheimer's, into the walls of medium-sized cortical arteries. This makes the vessels fragile and prone to rupture, resulting in hemorrhage specifically localized to the cerebral lobes. We call it a lobar hemorrhage, and that location distinguishes it from the deep bleeds caused by hypertension.
Finally, the thunderclap event. Subarachnoid hemorrhage, SAH, most famously linked to Berry aneurysms.
SAH is typically the result of a ruptured saccular or Berry aneurysm, and these aneurysms are usually not acquired through standard wear and tear. They're believed to result from congenital developmental defects.
A weak point in the vessel wall.
A weak point where the necessary medial smooth muscle layer and internal elastic lamina are deficient, usually at major arterial bifurcations.
And their locations cluster around the circle of Willis.
Precisely. They are mostly found on the anterior circulation. The single most common site is the anterior communicating artery, accounting for nearly 40% of cases. When one ruptures, the blood pours directly into the subarachnoid space, causing that acute meningeal irritation, the classic worst headache of my life.
The visual must be intense.
It is. The base of the brain is just covered in blood. Beyond the immediate catastrophic effect, a 50% mortality rate, the blood can later cause scarring, blocking CSF flow and causing hydrocephalus. Or, critically, breakdown products of the blood can induce severe cerebral vasospasm days later, leading to a delayed ischemic stroke.
Shifting gears again, how do microbial invaders breach the fortress of the CNS? What are the primary routes pathogens use to bypass immune surveillance?
Well, the defenses are rigorous, but there are four main vectors. Most commonly, it's hematogenous spread pathogens traveling through the bloodstream. But they can also reach the CNS via local extension, say from an infected middle ear or sinus.
Or traveling along nerves?
Yes, traveling along the peripheral nerves, which is classic for rabies or herpes, or less commonly, through direct CSF seeding after a penetrating injury. And these routes lead to three main clinical syndromes: meningitis, which is inflammation of the linings; encephalitis, inflammation of the brain tissue; and abscesses, those localized pockets of infection.
Let's start with the rapidly dangerous acute pyogenic bacterial meningitis.
This is a raging inflammatory process in the subarachnoid space. Grossly, when you look at the brain, you see a thick, striking yellow-green suppurative exudate.
Pure pus.
Pure pus coating the leptomeninges, visible over the surface, particularly filling the sulci.
And microscopically, what is that exudate made of?
It's a dense sea of acute inflammatory cells, primarily neutrophils, filling the subarachnoid space, and the specific bacteria change with the patient's age.
Right, E. coli in newborns and meningitis in young adults.
And S. pneumonia in older adults, and the immunocompromised.
Next, cerebral abscesses, a localized destructive infection. What makes an abscess fundamentally different from diffuse meningitis?
The defining feature is the body's attempt to contain the damage. An abscess is a localized sphere of liquefactive necrosis.
Destroyed, liquefied brain tissue.
Yes. And if you look at the H&E slide, the core is necrotic tissue and acute inflammation, but this core is surrounded by a robust, well-defined capsule.
And that wall is built by
Proliferating fibroblasts and new blood vessels. Outside this capsule, you see an intense zone of surrounding reactive gliosis, where astrocytes are building a final scar barrier. This organization liquefactive core, fibrous capsule, glial wall is the diagnostic sign.
Okay, now focusing on the viral agents. They're fascinating because they don't cause widespread pus, but instead leave these specific telltale intracellular signatures.
Right. Viral infections primarily cause encephalitis, inflammation centered in the parenchyma. The classic viral hallmarks are 1. Perivascular cuffs of lymphocytes,
So lymphocytes clustering around blood vessels.
like small donuts of inflammation. And 2. Microglial nodules, those clusters of activated microglia responding to scattered neuronal death.
Let's do a deep dive into herpes simplex virus type 1, HSV1, which causes a particularly devastating form of necrotizing encephalitis.
HSV1 has a specific brutal target: the inferior and medial temporal lobes and the orbital frontal lobes. Clinically, this leads to seizures and severe behavioral changes. Grossly, the pathology is striking. It is extensively destructive, hemorrhagic, and necrotic.
What's the microscopic diagnostic clue for HSV1?
While the necrosis is visible, the definitive diagnosis comes from finding neuronal viral inclusions. These are intranuclear inclusions found inside both neurons and surrounding glial cells. They represent the visible products of the viral replication cycle.
And the classic rapid diagnostic finding for rabies.
Rabies encephalitis, transmitted through the peripheral nerves, is pathologically defined by the presence of Negri bodies.
Okay.
These are unique, brightly eosinophilic cytoplasmic inclusions, and although they can be found throughout the CNS, they are most reliably found in the large, beautiful Purkinje cells of the cerebellum and the pyramidal neurons of the hippocampus. If Negri bodies are present, the diagnosis is confirmed.
Finally, the CNS pathology is tied directly to immunosuppression, particularly HIV.
HIV itself can cause HIV encephalitis. The key pathological finding here is the formation of microglial nodules that characteristically contain large, multinucleated giant cells.
And those are formed by?
The fusion of macrophages that have internalized the virus.
And in severely immunosuppressed patients, you get opportunistic infections.
Right. The dormant JC polyomavirus can reactivate, causing progressive multifocal leukoencephalopathy, or PML. This virus targets and destroys the myelin-producing cells, the oligodendrocytes. This results in widespread, ill-defined patches of demyelination in the white matter.
We move into the chronic dismantling diseases of the nervous system. We'll start with the attack on the protective insulation, the myelin sheath. Demyelinating disease.
The prime example is multiple sclerosis, MS.
Okay.
This is a primary autoimmune disease where the body's immune system, mediated by T cells and B cells, attacks the myelin components in the CNS.
And there's a genetic and environmental component.
Yes, genetic susceptibility is linked to HLA types, and environmental factors like low vitamin D or geography are known contributors.
The characteristic lesion is the MS plaque. How do we visualize and describe the morphology of this injury?
MS plaques are found almost exclusively in the white matter, often clustered around the ventricles. Grossly, they are firm, well-circumscribed gray areas. Microscopically, we have to distinguish between the active and inactive phases.
So what does an active plaque look like?
That's the site of active myelin destruction. You see intense inflammation, perivascular lymphocyte cuffs, and critically abundant foamy macrophages. These macrophages are full of the breakdown products of myelin. They are the visible agents of destruction.
And the inactive plaque?
That represents the healed chronic injury. The inflammation has subsided, and what remains is a dense acellular area dominated by gliosis, the astrocyte scar. Importantly, in MS, the axons within the scar are generally spared, though the loss of insulation makes conduction impossible.
And now, the relentless march of neurodegenerative diseases, defined entirely by specific proteins gone rogue. This area is truly fascinating because the whole pathology revolves around just a few misfolded building blocks.
The unifying principle here is protein aggregation. Normal, often soluble, proteins like tau, A-beta, alpha-synuclein change their shape into insoluble, misfolded, toxic isoforms. These aggregates resist the cell's disposal mechanisms, they accumulate, and they eventually choke the neuron, leading to selective neuronal death.
Let's start with the most aggressive form of aggregation. Prion diseases, specifically Creutzfeldt-Jakob disease, CJD.
CJD causes a rapidly progressive dementia. The mechanism is unique. The normal cellular prion protein, PRPC, misfolds into the infectious isoform, PRPSC.
The beta-pleated sheet form.
Right. And this infectious version acts as a template, forcing other normal proteins to also misfold in a chain reaction, which is why the disease is transmissible.
And the microscopic result of this propagating misfolding?
Spongiform change. This is the appearance of numerous small, uniform vacuoles or holes in the neuropil, the gray matter, giving the brain a distinct sponge-like appearance. This vacuolation, combined with rampant neuronal loss, defines the pathology.
Moving to the most common dementia, Alzheimer's disease, AD.
AD is clinically defined by progressive memory loss and global cognitive failure. Grossly, the brain shows significant cortical atrophy, particularly in the frontal, temporal, and parietal lobes.
And this loss of tissue makes the ventricles look enlarged.
Yes, a phenomenon we call hydrocephalus ex vacuo. It simply means the CSF fills the space created by the lost parenchyma.
Microscopically, the disease is defined by two coexisting protein pathologies. First, the amyloid beta, A-beta plaques.
These are extracellular deposits. They originate from the large amyloid precursor protein, or APP. In AD, abnormal cleavage by beta secretase and gamma secretase produces the toxic A-beta peptide. This peptide then aggregates outside the neurons, forming diffuse or dense neuritic plaques.
And the second hallmark, which is an internal disaster for the neuron.
The neurofibrillary tangles, or NFTs. These are intracellular aggregates composed of highly hyperphosphorylated tau protein.
And tau is normally a stabilizer for the neuron's internal transport system.
Exactly. It stabilizes microtubules. When it's excessively phosphorylated, tau detaches, clumps into paired helical filaments, and forms those classic flame-shaped tangles that clog the neuron. This loss of the internal transport system is believed to be the primary cause of neuronal dysfunction and death.
And it's the tangles, not the plaques, that correlate with the severity of dementia.
That's right. Intriguingly, the density of these intracellular tangles correlates most closely with the clinical severity of the dementia.
And the genetic risk factors here are a major insight.
The single most significant genetic risk factor is the ApoE epsilon 4 allele. Having one copy dramatically increases your lifetime risk. Having two copies accelerates the onset even further. ApoE is critically involved in regulating how A-beta is cleared and deposited, connecting the genetic risk directly to the core pathology.
Moving to movement disorders, let's discuss Parkinson's disease, PD.
PD is clinically defined by motor symptoms resulting from a specific localized neuronal death. Pathologically, we see a profound loss of the pigmented melanin-containing dopaminergic neurons in the substantia nigra and the locus ceruleus.
And this causes a visible change, doesn't it?
It does. This gross loss of cells causes a visible pallor in the substantia nigra region.
And the microscopic hallmark of the disease.
The presence of Lewy bodies. These are concentric eosinophilic cytoplasmic inclusions, often featuring a distinct pale halo. They're found within the surviving neurons of the substantia nigra and are composed predominantly of aggregated alpha-synuclein protein.
Finally, the purely genetic, devastating movement disorder, Huntington's disease, HD.
HD is an autosomal dominant disease caused by a large, unstable expansion of the CAG trinucleotide repeats in the Huntington gene. The pathology is one of the most anatomically specific in neurology.
Describe that distinct, localized gross atrophy.
You see severe and preferential atrophy of the caudate nucleus and the putamen, which together form the striatum. This massive loss of tissue causes the adjacent lateral ventricles to appear dramatically enlarged, a finding often termed boxcar ventricles on imaging. The loss of inhibitory GABAergic neurons in the striatum is what drives the hyperkinetic, uncontrollable movements, the chorea characteristic of the disease.
Okay, we conclude our deep dive with the diverse spectrum of primary and secondary CNS tumors, where diagnosis often hinges entirely on molecular markers and minute microscopic features.
Before diving into specific types, two general concepts are key. First, CNS tumors are classified by their cellular origin: gliomas from glia, meningiomas from meninges. Second, in adults, the most common tumors found in the brain are actually metastases from other primary sites.
Predominantly lung, breast, and melanoma.
And kidney, yes.
Okay, focusing on the most common and challenging primary type.
Yeah.
The astrocytomas, which are graded 1 through 4.
Diffuse astrocytomas, WHO2, and anaplastic astrocytomas, WHO3, are intrinsically infiltrative. They don't have defined margins, making complete surgical resection impossible. Microscopically, we see hypercellularity and nuclear atypia. The key insight here is molecular. The presence of IDH mutations is now a standard prognostic marker, often correlating with a better outcome.
And at the apex of malignancy, glioblastoma, GBM, WHO grade 4.
GBM is the most common and notoriously aggressive adult glioma. Grossly, they often have a variegated appearance with areas of hemorrhage and necrosis. On imaging, this translates to the classic ring enhancement pattern,
Where the viable tumor cells form a ring around the necrotic center.
Exactly.
The microscopic findings for GBM are pathognomonic. They are the definition of grade 4.
Absolutely. The two defining visual features are: 1, pseudopalisading necrosis. This is a bizarre architectural feature where highly malignant tumor cells align themselves like a fence or a picket line around areas of central geographic necrosis,
Suggesting hypoxia.
a high rate of hypoxia and cellular desperation. And 2, microvascular proliferation. The tumor attempts to recruit blood supply by building abnormal, hyperplastic, tangled formations of blood vessels. These two features together define GBM.
In stark, refreshing contrast to GBM, we had the highly curable pilocytic astrocytoma, WHOI.
These are generally the good news gliomas, common in children, often found in the cerebellum. They're usually cystic and circumscribed. The microscopic identification relies on specific morphology. They exhibit a biphasic pattern of loose and dense tissue and contain eosinophilic corkscrew-shaped structures known as Rosenthal fibers. These fibers are diagnostic.
Next, the unique appearance of the oligodendroglioma.
These tumors typically arise in the frontal or temporal lobes and are often associated with calcification. Microscopically, they have one of the most recognizable appearances in CNS pathology:
The fried egg appearance.
the classic fried egg or honeycomb pattern. The cells have clear empty halos around their central nuclei, and their prognosis is highly dependent on a key molecular marker, the presence of the 1p19q codeletion.
Which indicates chemosensitivity and a better outcome.
Right.
Moving to tumors of the ventricular lining, the ependymoma.
Ependymomas arise from ependymal cells. In children, they most commonly arise in the fourth ventricle, often causing obstructive hydrocephalus by blocking CSF flow.
What's the microscopic arrangement that defines ependymomas?
They form paravascular pseudorosets. This means the tumor cells radiate outward, arranging themselves around a central blood vessel, leaving in a cellular fibrillary zone immediately adjacent to the vessel wall.
The most common malignant pediatric brain tumor, medulloblastoma.
Medulloblastomas are highly malignant, primitive, embryonal tumors, almost always arising in the cerebellum of children. Microscopically, they are highly cellular, a classic example of a small blue cell tumor. They exhibit signs of primitive neuronal differentiation, specifically by forming circular structures called Homer-Wright rosettes.
And they are notorious for spreading through CSF.
Yes, resulting in drop metastases throughout the neuraxis.
Our final tumor type, one that grows outside the brain parenchyma, attached to the dura, meningioma.
Meningiomas are the most common benign primary CNS tumors originating from the arachnoidal cat cells. They're typically slow-growing and compress the brain rather than infiltrate it.
And their unique microscopic architectural signature.
They're defined by a characteristic whorled pattern of cellular growth, where the cells spiral tightly around each other. Furthermore, they frequently contain pathognomonic findings called psammoma bodies.
These small circular calcifications.
Yes, concentrically layered calcifications. The combination of whorling and psammoma bodies makes the diagnosis straightforward, usually indicating an excellent prognosis following resection.
So what does this all mean? We've completed a massive conceptual and visual journey, covering everything from the acute death of a single cell, that swollen red neuron struggling with hypoxia, to the large-scale architectural chaos of glioblastoma. We've seen the body's limited tools for repair, whether it's the fibrous scar of gliosis or the attempt to wall off an abscess.
The common thread, running through vascular insults, trauma, and proteinopathies, is the sheer fragile complexity of the CNS and its unique, rigid rules for injury. We've demonstrated that the brain reacts to injury in limited, predictable ways: cellular swelling, reactive scarring, specific immune responses. But it's the underlying cause and the resulting architectural detail that determines the diagnosis and prognosis.
Right.
Understanding these distinct visual pathologies is really the shortcut to mastering the field.
And as you, the learner, synthesize these nuggets, remember this crucial insight. Pathology is rapidly becoming a molecular science, even in seemingly stable diagnoses.
Ooh.
While we rely on the visual definitions, the psammoma bodies, the perivascular pseudorosets, the fried egg cells, the molecular underpinnings are what truly guide treatment today.
And that brings us to the final provocative thought for your further exploration, which centers on that interception of structure and prognosis. We've seen that the pellicetic astrocytoma is a WHO grade 1, generally benign tumor defined by its Rogenthal fibers. Yet we now know that nearly 90% of these benign tumors harbor a specific gene fusion, the IAA 1549BRAF fusion. And this reminds us that even within the most stable, benign pathological entities, the molecular detail is the ultimate key. It tells us not just what the tumor is, but why it formed, and how we might someday target its core vulnerability, continuing the deep dive into personalized therapy.